Imagine inserting like a standard FDA-approved medical device
Hmm.
to treat just routine menopause symptoms, right?
Right.
But instead of getting relief, it triggers this excruciating chronic pelvic pain. Or, it gets so stuck that you actually need surgery to forcibly extract it.
Yeah, it sounds like an absolute nightmare.
It really does. And imagine that the root cause of this nightmare isn't some defective device. It's actually a hidden biological blueprint left behind by a bacterial infection that you fought off like 20 or even 30 years ago.
It completely shatters that assumption we all have,
Yeah,
that the human body just undergoes this clean factory reset after an illness.
exactly.
We tend to view healing as just, well, a return to baseline. You get an infection, you take the prescribed antibiotics, the bacteria are eradicated, and the chapter is closed.
Right, problem solved.
But the reality of our internal anatomy is far more architectural. Tissues and blood vessels, they literally remodel themselves to survive the crisis. And that remodeling doesn't just magically disappear when the bacteria do.
Welcome to today's deep dive. Today, we are exploring a highly specific, totally fascinating medical puzzle. We're looking at whether a history of severe pelvic inflammatory disease, or PID, can permanently alter how your body's local blood flow and tissues respond to something as seemingly simple as a vaginal estrogen ring.
It is a very targeted question, but honestly, it serves as a masterclass in human anatomy.
Oh, absolutely.
The implications of this kind of collision between past infections and present treatments, it goes way beyond just one demographic or, one specific device.
For sure. Even if you never use an estrogen ring, and even if you haven't had PID, understanding this dynamic completely changes how you view your own medical history. It really shows that your past is physically built right into your present.
Yeah, it really is.
So to get into the mechanics of this, we have two main variables to introduce for you. First up is the vaginal estrogen ring, devices like S-ring.
Right, the ring itself.
Yeah, it's an off-white, soft, flexible ring. You place it in the upper third of the vagina, and it just stays there continuously for 90 days.
And its main purpose is to release a very steady, localized dose of estradiol, right? Which is an estrogen hormone.
Exactly. It releases it directly into the surrounding tissue to treat postmenopausal symptoms. Things like severe dryness, atrophy, or pain during sex.
Okay, and the second variable here is the environment we are placing this device into. Specifically, an environment that has been, well, ravaged by severe pelvic inflammatory disease.
Let's unpack PID a bit.
Yeah, so PID is an ascending bacterial infection. It typically starts in the lower genital tract. It's often triggered by sexually transmitted bacteria, like chlamydia or gonorrhea, though other common bacteria can be the culprits too.
Right. And what makes PID so destructive isn't just that it exists, it's that it doesn't stay localized to the cervix.
Exactly. It ascends, it moves aggressively upward into the normally sterile environment of the uterus, the fallopian tubes, and the ovaries.
And this isn't just some mild superficial irritation we're talking about. The inflammatory cascade that happens when bacteria invade the upper reproductive tract is massive.
It's like the immune system essentially goes to war in the pelvis.
Yeah, you're looking at endometritis, which is a profound inflammation of the uterine lining. Then salpingitis, where the fallopian tubes become inflamed, swollen, and filled with fluid.
And ophiritis, right, the inflammation of the ovaries themselves.
Yes, exactly. And in the most severe cases, this infection creates what are called tubo-ovarian abscesses, which is just, it sounds awful.
It is awful. They are actual encapsulated pockets of infected tissue and trapped pus sitting deep inside the pelvis.
Wow. And the sheer physical pressure and heat of that level of inflammation, it fundamentally alters the surrounding structures, doesn't it?
It does. And here's the kicker. Even after you take a heavy course of antibiotics and the actual bacteria are dead and totally cleared from your system, the collateral damage to the tissue is already done.
Because the healing process for an inflammation of that magnitude involves depositing dense fibrin and collagen.
Right. In other words, severe scarring. The delicate finger-like projections inside the fallopian tubes are often completely destroyed or just fused shut.
Wow.
You also get dense pelvic adhesions forming. These are essentially thick bands of scar tissue that can cause organs like the uterus, the bowels, and the ovaries to literally stick together.
Oh my gosh. So instead of a resilient, highly elastic pelvic floor, you were left with these rigid structures.
Exactly.
I was thinking about it, think of the pelvis like a city's intricate road network. A severe storm, which is the PID infection, sweeps through.
Okay, I like this analogy.
Right. And even after the floodwaters recede, thanks to the antibiotics, The roads are left with permanent potholes, detours, and altered traffic patterns. The infrastructure is just forever changed.
That structural rigidity is the perfect way to visualize it.
Mm.
And it is not just the organ tissue that changes, the blood vessels themselves remodel.
Really? The blood vessels too?
Oh, yeah. During an acute PID flare-up, the demand for white blood cells and antibodies is so high that local hemodynamics drastically shift. Yeah, Doppler ultrasounds, which measure the speed and direction of blood flow, they routinely detect significantly increased abnormal blood flow in the pelvic veins during acute PID. The vessels stretch out and engorge to accommodate the immune system's massive response.
Okay, so when that inflammatory storm finally passes, those blood vessels don't necessarily just snap back tightly to their original shape, like a brand new rubber band.
No, they don't. They can remain stretched out and compromised.
So, cut to decades later, and a doctor prescribes a vaginal estrogen ring. We are now taking a physical medical device and a continuous stream of hormones and introducing them into this precise area.
Right into this poorly remodeled, rigid, scarred internal landscape.
Exactly. And to fully grasp why this collision is so problematic, we have to look closely at the complex plumbing of vaginal drug delivery. Because, there's a reason doctors prescribe a vaginal ring instead of just having a patient swallow an estrogen pill.
Yeah, there's a huge physiological difference. The human vagina is remarkably dense with vascular supply. It contains this intricate, interwoven network of arteries and veins.
Specifically, the uterine, pudendal, and hemorrhoidal blood vessels, right?
Yes, all converging right there in the pelvic cavity.
And this creates a massive delivery opportunity for medications because it allows the drug to completely bypass the liver.
Which is key.
Yeah, because when you swallow a standard pill, it travels down your esophagus, dissolves in your stomach, and gets absorbed into your gastrointestinal bloodstream. But before that blood can circulate to the rest of your body, it gets funneled directly to the liver via the portal vein.
Right, and the liver acts like an aggressive bouncer at a club.
Exactly. Its job is to filter out toxins. So it aggressively metabolizes and breaks down a huge percentage of that oral medication before the drug can even reach the tissues that actually need it.
Pharmacologists call this the liver's first-pass metabolism. And because the liver destroys so much of the hormone, oral estrogen requires much higher doses to be effective.
Which brings us back to vaginal delivery. It circumvents the liver entirely.
Yes. The medication is absorbed directly through the vaginal mucosa and enters the systemic circulation without that aggressive initial filtering.
But more importantly, for our specific scenario with the estrogen ring, it triggers something known as the first uterine pass effect.
Yes, the first uterine pass effect.
Wait, let me push back on the geography of that for a second.
Yes, okay.
If the estrogen ring is sitting securely inside the vaginal canal, why does it have a first uterine pass effect? The uterus is a separate organ sitting above the vagina. Shouldn't the estrogen just absorb into the immediate vaginal tissue and stay localized right there?
I know, it seems like it should be a closed local loop. But the internal pelvic anatomy is far more interconnected than that. The reproductive organs do not exist in circulatory isolation.
Okay.
Blood from the middle and upper third of the vagina, which, by the way, is exactly where that 90-day ring is placed to rest.
Right.
That blood drains into the very same venous plexuses that service the uterus and the fallopian tubes.
Ah, so the blood vessels form a shared pool.
Exactly. It's a deeply intertwined venous web. Because of this shared drainage system, the estrogen molecules diffuse through the vaginal walls and are absorbed directly into this local circulatory pool.
So it doesn't just stay in the vagina?
No, the hormone concentrates in the pelvic cavity, physically bathing the uterus, the fallopian tubes, and the surrounding pelvic veins before it eventually circulates out to the rest of the body. You are delivering a highly concentrated dose of estradiol straight into the core of the pelvic infrastructure.
Wow. Which brings us to the first massive risk of combining these two variables. We have a physical 90-day device releasing hormones into an area that we know might be structurally rigid and heavily scarred from past severe PID.
Right.
Let's look at the physical collision first. The FDA prescribing leaflets and warnings for devices like Estring, they are incredibly explicit. They strictly state that these vaginal rings are not suitable for women with narrow, short, or stenosed vaginas.
Right, and a stenosed vagina is one that has abnormally narrowed, lost its natural elasticity, or developed rigid strictures.
And while things like AID-related atrophy can cause this, previous pelvic surgeries and severe inflammatory scarring are major culprits too.
Absolutely. To treat the most severe complications of PID, like those massive tubo-ovarian abscesses or the dense adhesions we discussed earlier, surgical intervention is sometimes absolutely necessary.
A surgeon might have to literally go in and remove infected tissue or separate fused organs.
Which, unfortunately, leaves behind even more scar tissue.
So we're taking a flexible but solid ring, about 2 inches in diameter, and trying to seat it into a vaginal canal that has lost its ability to stretch and
The
accommodate.
tissue is rigid.
Right. And when you wedge a foreign object into a constrained, restricted space and just leave it there for 3 solid months, the physical pressure against those unyielding walls causes severe localized trauma.
This is the exact mechanism behind what the clinical warnings call ring adherence to the vaginal wall.
Oh, wow. Ring adherence.
Yeah. When the tissue cannot expand to comfortably house the device, the constant unrelieved pressure triggers a localized inflammatory response. The vaginal tissue essentially attempts to heal over the constant friction point.
Wait, are you saying the ring literally embeds itself into the tissue of the vaginal wall?
I am. It becomes physically overgrown and attached.
Oh my God, the reality of that is horrifying.
It is.
Women who experience ring adherence often cannot remove the device themselves. In documented clinical cases, the adherence is so severe that it requires surgical intervention to carefully cut the device out of the vaginal wall,
And beyond just adherence, you have the risk of vaginal erosion.
where the tissue literally wears away under the pressure.
Yes, exposing deeper layers of mucosa. And erosion frequently leads to vaginal ulceration, so open, painful sores inside the canal.
And whenever you have an open sore combined with a foreign object retained in the body for 90 days, you introduce the risk of severe bacterial infections.
Exactly. The FDA literature explicitly warns about the risk of toxic shock syndrome, or TSS. While rare, TSS is a life-threatening, rapid-onset bacterial infection. By placing a long-term device in a structurally compromised, poorly remodeled space, you are essentially setting a trap for the tissue to break down.
So the physical infrastructure just can't handle the roadblock.
Yeah.
But the physical collision is only half of this puzzle, isn't it?
Right.
There is also a chemical collision occurring simultaneously within that interconnected blood flow. The ring isn't just a piece of plastic. It's a drug delivery system actively pumping estrogen into that shared pelvic blood pool we mapped out earlier.
To understand the chemical danger here, we have to look at the pharmacological properties of estrogen itself.
Okay.
Estradiol is not just a hormone that regulates reproductive cycles and bone density. It is an active venous dilator.
A venous dilator, so it widens veins.
Exactly. When estrogen enters the bloodstream, it interacts with the smooth muscle cells lining the walls of the veins. It causes those smooth muscles to relax, which forces the vein to widen and expand its diameter.
So it chemically forces the pipes to open up and get wider. Now let's introduce a condition from the sources called pelvic congestion syndrome, or PCS.
Yes, PCS.
PCS is this highly underdiagnosed condition characterized by a heavy, aching, chronic pelvic pain that worsens throughout the day, especially when you're standing.
And the root cause of this pain is varicose veins deep inside the pelvis.
Right, and the mechanism of a varicose vein is entirely dependent on the failure of microscopic valves, right?
Yes. Veins have a much harder job than arteries because they have to pump deoxygenated blood upward, fighting against gravity to get back to the heart.
That's a lot of work.
It is. To do this, veins contain tiny one-way valves. Think of them as small, swinging doors that open to let blood push up and then immediately snap shut, meeting tightly in the middle to prevent the blood from falling back down.
But when a vein dilates and gets too wide, the walls stretch out. And when the walls stretch out, those two little swinging doors get pulled away from each other.
Exactly. They no longer meet in the middle.
So the valve completely fails. Because the doors can't close, gravity wins, and the blood flows backward. And this backward flow is called venous reflux.
And that reflux causes the blood to pool and stagnate in the pelvic cavity. The veins become massively engorged, twisted, and swollen. Those are your pelvic varicose veins. And the sheer weight and pressure of that pooled blood physically stretching the nerves in the pelvis is what causes the heavy, chronic, dragging pain of pelvic congestion syndrome.
And the clinical pathophysiology of this pelvic congestion is heavily linked to two specific things. First, previous venous damage.
Right.
Veins can be damaged by the extreme stretching of pregnancy, but also by the massive abnormal blood flow and stretched vessels caused by the severe inflammation of a past PID storm. The veins are already compromised.
Yeah, the infrastructure is already weak.
And second, PCS is fundamentally linked to the vasodilatory effects of estrogen. In fact, PCS is virtually unheard of in postmenopausal women unless they are on hormone therapy.
Right, precisely because their natural estrogen levels have dropped, removing the chemical trigger that dilates the veins.
When you put those pieces together, the chemical collision just becomes glaringly clear.
It really does. Severe PID leaves a patient with a legacy of stretched, incompetent pelvic veins. The valves are already struggling to hold back the blood, but perhaps the patient's pain has subsided over the years as they entered menopause and their natural estrogen plummeted.
And then, that same patient uses a vaginal estrogen ring to treat, say, vaginal dryness.
And thanks to the first uterine pass effect, the localized delivery of estrogen, which is a potent venous dilator, travels directly into those exact same damaged veins.
So, if the veins are already damaged and sluggish from past pelvic trauma, putting a venous dilator like estrogen in there is like adding an extra lane to a highway that's already suffering from a traffic jam.
That's a great way to look at it.
It doesn't fix the traffic. The highway just widens, allowing even more cars to pile up, slow down, and pool in the pelvis.
The estrogen chemically forces those already weakened veins to dilate further. Whatever remaining functionality the valves had is totally destroyed because the vessel walls stretch too far.
And the reflex begins again.
Exactly. The reflex begins, the blood pools, and the patient experiences a sudden, severe exacerbation of their underlying chronic pelvic pain.
Wow.
The localized hormone therapy actively triggers a full-blown recurrence of pelvic congestion syndrome. The very treatment prescribed to bring physical comfort to the pelvic region ends up chemically overloading its already damaged circulatory system.
It is the ultimate domino effect, spanning across decades. Which brings us back to what this all means for you listening. Your medical history isn't just a passive list of past events sitting in a file cabinet or checked off on an intake form.
No, definitely not.
It is an active, permanent blueprint that continuously dictates your internal anatomy. A severe bout of pelvic inflammatory disease doesn't just come and go. It permanently alters the elasticity of the pelvic tissues and the architectural integrity of the local blood flow.
This underscores exactly why providing a complete, unedited medical history to your healthcare provider is critical. An infection you successfully fought off 20 years ago has left a structural legacy behind.
And that legacy completely changes how your body will absorb, process, and physically interact with new medications and devices today.
Yeah, exactly. A localized treatment like a vaginal ring might face physical roadblocks that lead to severe tissue adherence and erosion, or it might chemically trigger venous dilation that exacerbates a chronic pain you assumed was entirely unrelated.
The roadmap of the body is forever altered by the storms it weathers, which leaves us with one final fascinating thought for you to mull over. We've just mapped out how a past localized pelvic infection can permanently rewrite your body's local vascular response to a localized drug.
Right.
So, could other localized drug deliveries like transdermal pain patches or even highly targeted injected cancer treatments be acting completely differently inside your specific body compared to someone else's, purely based on the common infections, injuries, or inflammatory storms you fought off decades ago?
It's a huge question. The cellular memory of tissue is profound, and we are only just beginning to understand how deeply it impacts modern pharmacology.
Your past is quite literally built into your present, and your internal roadmap is entirely uniquely your own.